I welcome our chairperson, Dr. Parthopratim Dutta Majumder, for his keynote address, Updates in the Management of Uveitis.
Good afternoon. Thank you, Dr. Rajashree and Risha, for giving me this opportunity. So the topic, as you can see, the update in the management of uveitis. So I'll just divide my talk into first part. I'll talk about the update, what is the recent management in the uveitis, and second, I'll just conclude with 7 take-home points for not missing out or not committing any mistakes in the management of uveitis. So I don't have any financial interest in any of these drugs. So if you see the evolution of the drugs in uveitis, you will see that we are following the rheumatologist or the transfusion medicine specialist. What all they are using, we have started incorporating in our practice. So it started with corticosteroid, then we moved to immunosuppressive and biological. So the basic idea is to immune suppress the entire the body cells. So if you see the corticosteroid, what we do, we try to take the lymphocyte from intravascular space to the extravascular space, that such as bone marrow, spleen. So we just shift the lymphocyte from intravascular space to the extravascular space. Whereas in immunosuppressives, what we do, we try to kill the rapidly replicating cells. Whenever there is an inflammatory stimulus, so the lymphocytes, macrophages, they will come and start replicating at the site of inflammation. So immunosuppressives like anti-metabolite, they will just deplete these cells of metabolism, and sometimes the cytotoxic, they will just cause the lysis of the cell, and they will basically cause the immunosuppression by killing those cells. So that's why immunosuppressives are sometimes considered as a very prone to have much more side effects. So that's why there was a continuous effort to identify some agents which will cause theoretically at least minimum side effects. So that's how the biological came. The biologicals are basically the substances. These are biologically active substance. And why they call biologic? Because they are made with the help of biological technique, like we have the monoclonal antibodies and all. So they are basically, they just interfere with the transmission of the inflammatory cascade. Like if you see if there is a cytokine producing cell, so there will be cytokine production. So biological will go and just block the cytokine production rather than causing damage to the inflammatory cells. So the pathway will be disturbed, but the cells will remain intact. So that's how we have so many biologicals. I'm not going to discuss into that. One thing we have to remember, that we have so many varieties, and now we have fully human antibody. So we believe that fully human antibody like adalimumab and all these are, they won't cause any reaction. But you have to understand, anything foreign to our body will cause some kind of reaction. So even the fully human antibody, monoclonal antibody also can cause some inflammation. So that's why these drugs are often prescribed with oral methotrexate or oral steroid. Now, tips for biological uveitis. If you want to decide, first of all, you have to rule out the infection, discuss your treatment plan with patient and rheumatologist. Combination of the methotrexate, as I said, it is very important because you can maintain the long-term immunosuppression. When a period of inactivity, when the disease is inactive, then you can stop the biologic and continue the patient on methotrexate. And monitor your patient regularly, keep a watch on recurrence of inflammation. Now let's come to the good, bad and ugly of biologic. So the good part is, it is very useful treatment option in the treatment resistant cases. It is available as a injectable formulation, compliance is high and relatively faster onset of action. If you see the commonly available adalimumab, it's actually Tmax is after a single dose is almost 5.5 days. So it's a relatively rapidly acting drug which can be used in your clinical practice. I'll give you an example. A 52-year-old lady with known case of necrotizing scleritis for last 6 years, and you can see the patient was treated with on corticosteroid, cyclophosphamide, azathioprine, and resistant to all drug. IOP was significantly high. I'll just cut short the discussion so that I can finish all the slides. So the IOP was so high, the patient was in need of a Ahmed glaucoma valve. But because of active scleritis, it was very difficult to start the patient on, allow the patient to go for surgery. So here we have decided to inject the patients with one TNF alpha blocker, which is called golimumab. It's just like adalimumab only. So and methotrexate, we treated the patient. There was prompt resolution of that, and finally the patient underwent Ahmed implantation. So sometimes in conditions, for example, a patient with scleritis has developed a rhegmatogenous RD, and your vitreoretinal surgeon want to treat the patient. So you need a prompt control of the treatment. So in such scenario, where the treatment is not responding to any other modalities of treatment, these agents can be helpful. Now another scenario you see here, the oral steroid was used and oral methotrexate was used, and this scleritis patient kept on getting the recurrence, and there was almost perforation. So now in this perforation with active scleritis, you need to control the uveitis, and you have to scleritis, and then only you have to go for patch graft. So biological can be a very useful alternative in this scenario. So it decreases the recurrence rate of inflammation. So you have to little act early and taking a decision on biologic. So sometimes what happen, you will attend various webinar or lectures where people will tell you that the biological should be used at last. First you treat the immunosuppressive. Sometimes like where the scleral integrity or the patient's visual potential in danger. For example, a patient of Behçet disease, no point of treating the patient with 2-3 immunosuppressive, spending time when there is already damage has occurred, then to shift to biologic. So in these patients, you have to shift this patient to biological little early compared to the other patients. The bad for us is in a country like India, you can see it is very expensive. The cost per dose of adalimumab, yes, the biosimilar of adalimumab, which is administered every 15 days, is 6,000. And this is the cost if the patient is, if you are telling the pharmaceutical company to give it to the patient without going to pharmacy, then this is the cost. In pharmacy, the cost is much more higher. So cost is a very big factor. Like rituximab, which is often considered as a gold line treatment for scleritis also, so that is also become very expensive. So cost is the bad thing about the biologic. The ugly part is of the biologic is that the increased risk of infection. The TNF alpha blocker, when we talk about, so TNF alpha is a cytokine molecule. Now what is the function of cytokine molecule, we are not going to discuss, but one important thing we should remember is TNF alpha is responsible for safeguarding us against Mycobacterium tuberculosis. So in a country like tuberculosis, if you are giving anti-TNF blocker for a long time, patient is susceptible to develop or contract TB much more commonly than the other patients. So that thing you have to keep in mind, and you have to tell the patients also that you may be prone to infections. So this is a patient of JIA treated for at 4-year age it was diagnosed, and the patient was treated with oral methotrexate and adalimumab for a long time, and developed pulmonary TB after 9 years of treatment of adalimumab. So sometimes it can happen, but it is treatable. The child was successfully treated with ATT, but patient also developed some choroidal nodule, which was due to the tuberculosis only, and this was also treated. This is another patient on long-term immunosuppression for 8 years and developed a toxoplasma lesion, but it was managed with intravitreal and systemic medication. So it is all about balancing when to use the drug. You have to understand that it's all about balancing the risk and reward. So you have to take the call judiciously. Now there is another molecule which has emerged out as a poor man's biological, you can call the JAK inhibitor. So JAK signaling, again I am not going into that, it is another pathway which prevents, which is used in the inflammation. So this drug actually prevents that pathway. It is FDA approved for rheumatoid arthritis, psoriatic arthritis and ulcerative colitis. So the tofacitinib is the very useful molecule. It is very useful in exudative RD and various other conditions. Why? It is basically small molecule, so theoretically it is more common to more easily it can penetrate the blood retinal barrier and can reach the eye easily. So that's why tofacitinib is becoming very popular. So we have the largest series from this scleritis. It was our first case report from India, and then we with Professor Ramanan of Bristol, we use it first in the children in uveitis and scleritis, and the responses is really good. The tofacitinib scleritis also we have published a large series on adult patient also. So responses are good. And who are the ideal candidate? The patient who cannot afford the biological treatment, the needy people for whom the biological costs are too high. It can be done because each tablet is 20 rupees only. So per day cost is only 40 rupees. Now, these are some examples. I'm not going into that. These are all treatment resistance cases of scleritis which ultimately responded to tofacitinib. This is another important to highlight that tofacitinib sometimes can cause viral reactivation. These patients of scleritis responded but developed some viral stromal keratitis which was treated with antiviral, and there was no need to stop the tofacitinib treatment. Also, some patients we have encountered that herpes labialis is developed after 1 month of use of tofacitinib. So it's not that we are only promoting the tofacitinib for all cases. You have to remember that the herpes infection can be there. So you have to tell the patients about that. And another side of that, there is a history of tuberculosis related cervical lymphadenopathy, and we could treat them without there was any reactivation of the TB. So this is another children who was not responding to methotrexate and mycophenolate, but finally responded to tofacitinib. So just I'll conclude with 7 signs to avoid in uveitis management, which will be helpful for all, but it is a common all only. First is that avoid the incorrect use of eye drop. You have to understand that many a time we treat the posterior segment lesions with eye drop. So posterior uveitis, panuveitis and intermediate uveitis, you have to understand that eye drop cannot treat the drop in vision. So you have to always use the systemic medication. Second, incorrect use of using topical drop is don't use the cyclopentolate. Cyclopentolate is a medicine which is chemoattractant. That means it will attract the inflammatory cells to the site of inflammation. So treating the inflammation with cyclopentolate is just like calling a bull to come and hit you. Now, sometimes what happens, you start the medicine atropine, long-standing, which has a long-standing effect, and the topical steroid you gradually taper down. So, if your tapering of the topical steroid is too high, quickly you are just tapering the topical steroid, but patient is on atropine, there are chances that patient can develop synechia in dilated pupil, and that patient will cause lot of trouble because you will have lot of photophobia and all. So beware of that. Any patient, for example, this is a patient of anterior uveitis treated with iridocyclitis. Lot of investigation was done and started on topical steroid and cycloplegic. But this is the patient, you can see the view. If you are doing a 90D examination, it will look like this. But if you just do the peripheral examination, you can see that this was a case of acute retinal necrosis. So dilated fundus examination is must. Second important thing is that always look beyond the eye. Sometimes what happens, we don't look beyond the eye and only treat that eye. For example, a patient of anterior uveitis, if you don't try to delineate it that how far the spectrum is, you will miss the other ocular manifestation. And if you don't take care of all these things, then you will miss the systemic manifestation also. That's why the Chinese saying is there that the unlucky doctor treats the head of the disease and the lucky doctor its tail. So you have to treat from head to tail of the disease. Now, I'll give you an example. If you just treat a case of bilateral granulomatous uveitis only with topical steroid and cycloplegic, you will miss seeing that the patient may have vitritis or exudative retachment. So this patient, ultimately the extended spectrum says the patient may have alopecia, vitiligo and tinnitus. So you have to overall give the immunosuppression to control the overall disease, not only the systemic medications. So this is again another patients was treated with HLA as a fibrinous reaction, so was considered as a HLA-B27, but HLA-B27 was negative. Patient lost to follow-up. The patient went to another hospital, tertiary center, and there it was diagnosed, treated as a TB because Montu test was 20 millimeter. So, and HLA-B27 was negative, so they thought that it is TB only. So treated with TB, patient developed deranged LFT, recurrence not stopped, kept on getting recurrences. Patient also developed backache by that time, and again when he came back, we again repeated the HLA-B27. This time it was positive. So rheumatologist diagnosed it as a ankylosing spondylitis. So sometimes you have to understand that we cannot treat the laboratory investigation, and sometimes HLA-B27 can become positive at later part of the disease also. Next, few drugs, these are notorious to cause inflammation, so always take the history. If you don't know the name, the commercial name, just Google search, you'll get the name and check that whether the uveitis is because of any of this drug which are the culprit. And don't use the suboptimal use of drug, like this kind of the side threatening condition. No point of treating these patients with only immunosuppressive biologic or a low dose of steroid. What you have to do, you have to understand that all this immunosuppressive we are discussing, they have a long actually onset of action. You see here mycophenolate, it takes month to act. Methotrexate takes at least 3 months to start acting. So these are the drug which cannot help them. Only drug which can help is that the methylprednisolone or the IVMP, pulse steroid. So it has been seen that it takes almost, in an inflamed eye, it takes only 2 hours to reach the eye. So the pulse corticosteroid is a valuable option here. My last slide, this is about the children. That mistake in treating the uveitis we do in children is that you have to remember that JIE is a notorious cause. Most of the childs are blind in pediatric uveitis because of this condition. So you have to always remember how to identify that. So complications are very high. You have to see any child presenting with BSK, tilting of head, squinting. You have to make sure there is something gross abnormal. Hunt for the inflammation. Always treated as a because JIA are white eye uveitis, so often treated as a allergic disease. So you have to sometimes take them for examination under general anesthesia. Immunosuppressive remain the mainstay. Don't treat a children with uveitis with topical steroid. Steroid drops are not for the children. Always you have to rely on the immunosuppressive. And you have to understand that lens, intraocular lens, there is no fixed rule. You have to carefully see that whether the child is inflammation is controlled or not. Otherwise, just leave the child aphakic. Sometimes it's just our ego. For that we put the lens, and finally the child will develop lot of other problem, and finally that require IOL explantation. So remember that IOL is very there no fixed rule. You have to decide very carefully, and the drops should not be used. Very minimally you should use in treating the pediatric children. Thank you.
Thank you, Partho sir. That was an excellent talk, and especially the pearls and management was very